let's begin what exactly is contrast-induced nephropathy. So, by definition, it is 25% increase in serum creatinine 48 hours after administration of contrast. So, what does contrast do? It has a direct necrotic and apoptotic changes in the tubule. Okay, so it increases reactive oxygen species and it leads to arteriolar vasoconstriction. So, all in all, it results in impaired renal function. So as I had already said, the intravenous sodium bicarbonate and oral N-acetylcysteine are widely used to prevent acute kidney injury after angiography. So is there any direct evidence although for their efficacy? So we have multiple randomized controlled trials. They show it has been equivocal. Hasn't actually, there have been negative reports about sodium bicarbonate. For N-acetylcysteine, it has been equivocal. Does it really help us to prevent? So in PRESERVE trial that was done in Australia, it was a multi-central trial in Australia. It's not an Indian data, but yeah, it is a pertinent data. So around 5,000 patients with high risk for renal complication were scheduled for angiography. And what is high risk? So eGFR from 15 to 45 ml per minute in normal patients without diabetes, or eGFR 45 to 60 in patients with diabetes. Okay. Exclusion criteria: if there was an emergency angiography, patient with decompensated heart failure, and already those who were in AKI, and patient who did not consent and obviously pregnant women, they were not included in these criteria in the trial. So the trial design was 2x2 factorial design. 2x2 factorial design means there are two arms and with 4 interventions. 2 interventions in each arm. Okay? There are 2 groups and 2 interventions in each group. So patients with renal complications were randomized to receive, in one arm, there was in one group, there was sodium bicarbonate with normal saline. In another group, we had 5 days of oral N-acetylcysteine and any oral placebo. Okay. All of the patients, nevertheless, irrespective, received IV fluid. Okay. So the range approximately 1 to 3 ml per hour for 1 to 2 hours, 1 to 3 ml per kg per hour before the procedure, 1.5 to 2 during the procedure, and again. So all in all, you can say around 1 to 3 ml per hour per kg throughout the time they received IV fluids. Okay?
So which particular fluid is IV fluid is used?
Yes. So they received normal saline, isotopic, not balanced salt solution. All of them received balanced.
Okay, so the 5 days before you get normal saline alpha sodium bicarbonate એમાં કેટલું હતું?
Yes sir, can you repeat that?
So in that previous 5 days in the first term where 2 treatments are going on sodium bicarbonate and normal saline, in those 5 days how many of them were given?
Irrespective of that, 5 days of oral N-acetylcysteine, irrespective of that they received normal saline. The N-acetylcysteine group did not receive soda bicarb. There was no interaction between
You are not getting my question. In that sodium bicarbonate arm, the comparator arm is sodium chloride, which is normal saline, right?
Yes.
So what amount of normal saline was given at that time?
At that time?
Yes.
Okay.
Pre-procedure.
Pre-procedure, yeah, we have written. So 1 to 3 ml per kg per hour they have received. Okay. The soda bicarb group received.
That is for all the patients, na?
All the
Regardless
patients.
of arms. So
All the patients. Okay.
Okay, you go ahead. We'll discuss later.
So all the patients, the only difference being here, the normal saline people did not receive soda bicarb. Okay. So see.
1 to 12 hours is very.
Yeah, 1 to 12 hours. It's like it was the inclusion criteria. Some patients who did not undergo angiography immediately. Prior to angiography, also they were in the ICU, for example, but they did receive IV. So this is the trial design, that is 2x2 factorial. So one group you can see it is N-acetylcysteine versus placebo. The another group was sodium bicarbonate versus sodium chloride. So what were the primary endpoints? We had 90 days mortality in both the groups. Is there any need for renal replacement therapy? Or if there was a persistent 50% increase in serum creatinine from the baseline. Okay. So it was an intention to treat analysis. The and the N-acetylcysteine had around 83 patients, and the bicarbonate had come at 9 patients. Okay, so the interim analysis was done after the 50% of the patient reached for 90-day follow-up. So the average age in each group was around 70 years. 81% of them they were diabetic. Most of the patient, 90% of the patient went coronary angiography. So this was done in a center where all angiographies were done, not just coronary angiography. But nevertheless, most of the patient underwent coronary angiography only. So that's why we can extrapolate the results on our center as well.
So that should mean that they must not be patient of acute coronary syndrome,
No,
right?
80% of them they went coronary angiography. That means they
Yeah,
presented.
but in your inclusion criteria and exclusion criteria,
Exclusion criteria, it is decompensated heart failure, not
Yeah.
necessarily.
emergency angiography as well. So
Yes, sir.
emergency angiography was one of the exclusion criteria.
Yes,
So
sir.
acute MI should be an emergency angiography.
So not necessarily all the patients, those who went, did not have acute coronary syndrome. It's like it was a generalized. Even they received for contrast enhanced CT for abdomen. So it was a generalized one.
Yeah, that's fine. But if a
Yeah.
patient comes with an acute coronary syndrome in a cardiac center like this, right? So and you are subjecting this patient to coronary angiogram, will you consider this an emergency angiogram or not non-emergency angiogram?
Yeah, so that's what only 1/3 of them had a coronary intervention. So most of them were elective. Because if you can see the second
90% most of them were elective. That's
Yes.
interesting.
Yeah, so that's why. So that's why this trial had a very high type 2 error. That's why it was not extrapolated, and that's what we got to
What is the meaning of the first statement?
What I didn't get you.
The first statement you
Yeah,
said.
the trial was halted for futility. The trial was halted for futility at the interim analysis. So 5,000 patients when they have come. So at that time also they realized that the results are equivocal. We need not enroll more patients. That is the
Futility is in it's a more slang word rather than something else. So
Which?
what they actually found?
halted for futility. You think it is a slang word? It is a normally used word in all the RCT
If you
discussion.
are
It's not a
enrolling
slang word.
5,000, 8,000 patients
Yeah.
and you put a word that is futile.
No. It's not a slang word, sir. It's a very well-known word in biostatics if you have read about it. Futility of interim analysis. It means even at the 5,000 patient, they analyze the results will be equivocal. We need not put in more. It's not a slang word. Okay. It's a very well-known word for biostatics. I'm sure you have attended previous learning clubs also. Okay. So let us just come down. What did the further subgroup analysis told us? So in non-coronary angiographies, it was seen normal saline was superior to soda bicarb. So the non-coronary angiographies, which meant contrast enhanced CT scans for CT abdomen and CCT pulmonary. Okay. So among the patient at high risk of AKI following angiography, renal outcomes were not different for normal saline versus soda bicarb, nor were they different for acetylcysteine or placebo. So-
what we practice in short.
Yes. So this was not extrapolated all over the world because this was not a multiple nation. It was done in one particular nation where they found since it is N-acetylcysteine or soda bicarb, it is not producing any further results, as it was published in NAJM in 2018. So there came a practice. All we need to do is to maintain the patient in euvolemia. That was the conclusion of this trial. So that's what we do here also. We maintain the patient in euvolemia. Euvolemia means the patient is not getting very negative or very positive. What result it's actually producing, we should have a concrete evidence for it or against it. So if we keep the patient in euvolemia, the results after 48 hours, it's the same. The EGFR remains the same. So that's what has been
not use this and acid
Yes,
alcohol,
it's,
nothing like
it's
that.
not, it
That
doesn't
is a
give you
simple
any
message.
result.
It is.
It doesn't help or harm the patient.
हाँ, it is anecdotal.
હા તો ખરું ને કોસ્ટ કેટલી વધી જાય યાર તમે એન એસિટાઇલ સિસ્ટીનની કોસ્ટ તો તમે જુઓ 60
So that
70
that exactly was the reason to discuss it. If it is not producing any result, let's just quit it.
So what was the other studies which actually showed some benefit by acetylcysteine?
So there was ACT study, ACT study. Even it showed it is equivocal. It does not. There has been no randomized controlled trials or meta-analysis which shows the N-acetylcysteine helps. There has only been observational studies. And observational study you cannot extrapolate in your practice. The highest level of evidence is what? What's up? What is the highest level of evidence?
એ
नहीं मैं उनसे पूछ रही हूँ. What is the highest level of evidence? Meta-analysis.
Meta-analysis.
Yes.
Right? So if you go through the hierarchy of the
Yes.
evidence-based medicine,
It is
the
meta-analysis.
Right? So in that study they given 40 ACT, right? It was done in which country?
I don't remember. So, but it is.
So in that particular study, they have actually proven statistically significant difference in patient undergoing angiogram, right?
So that-
In terms of, listen, in terms of improvement in the avoidance of the worsening of the kidney issues, and that is why even in the European guidelines, it is still there in acetylcysteine, though it is not been accepted all
Yes,
over the
it's
world.
not. It's equivocal.
And
All
what
the
is the
meta-analysis are saying-
mechanism of action it has been implicated for improvement or rather
It prevents superoxide.
So it is the antioxidant
Yes.
mechanism of action,
So
right?
it is equivocal. It hasn't produced any concrete evidence. We can say that we should incorporate, extrapolate it in our practice.
See, is there any difference in contrast use? Whether patient is having normal kidney function or
Yes.
abnormal enough?
So that's what already in all these studies, the patients who have been included were high risk for renal abnormality. That means that EGFR was already compromised.
EGFR base that is 15 to 45 in normal patient and more than less than 16 diabetic.
I find whether the contrast use was different for both the normal kidney function or
No sir, it was the same.
say
It was the same. So the issue is if your kidney is normal, right? So if you are decreased risk for apoptosis, necrosis and generation of reactive oxygen species. But if you are already compromised, then it becomes one of the risk factor for getting contrast induced death.
Yeah, with many studies they do check with high osmolar contrast media as well as low osmolar contrast media, and what they actually found is that probable benefit
Definitive
is
is
not
high
in low
osmolar.
osmolar contrast media, right? So in a high osmolar most of the time we are not using it right now, but if it is used, then this particular molecule are never going to help because the impact on kidney with high osmolar contrast media is very
That's